Morning, everyone. I'm Russ Houghton. I'm an MSK radiologist at Gajan and St Thomas's. So I've got 7 minutes, which I've just found out, to talk about imaging in the presence of spinal metalwork. So the scenario is we image the spine post-surgery. The routine is routine post-operative films. They're seen in clinic 6 weeks later. They're probably seen in clinic at about a year. If they're all fine, they're discharged. So you might see 2 or 3 post-operative x-rays. We don't cross-sectionally image people who are doing well, because if you find something, you're not going to do anything about it. Where cross-sectional imaging comes in is when there's a problem. So for post-operative complications, where's the screw? Where's the pedicle screw if someone develops leg pain post-operation? Is there a hematoma, or is there any infection? Pseudoarthrosis or failure of fusion, again, this is later down the line, generally from a year onwards. We've got basically CT and X-ray to try and look at that. Remember, it can take a year to form a fusion, so don't as a radiologist, don't start calling a pseudoarthrosis 2 or 3 months after the operation where you can't see any bone graft. And finally, degenerate changes, which we'll move on to. Here's a normal X-ray, which is a year post-op. The patient's happy, the back pain's gone, and you can see that they've had 2 fusions. The fusion at the top, with the pedicle screws, is the more recent one. It's got a metallic cage. There's no evidence of loosening. The cage hasn't subsided. The patient's really happy. He had a previous fusion about 15 years ago, excuse me, which is an anterior fusion, and that's done with a femoral ring allograft. And you can see it's much easier to see the fusion there because you've got a ring allograft, you've got bone in there, and you've got no metal. Well, the patient was happy, patient's discharged. Second happy patient, he had a ALIF at 2 levels about a year ago. And again, you can see extensive solid fusion through that graft at both levels. On the right side, you can see solid posterolateral fusion mass as well. Here's another happy patient. He's had surgery at two separate surgeries. You can see ACDF at C5-6 and C6-7, and there's extensive solid fusion there. And you can also see solid fusion on the X-rays, and the CT scan just confirms it. Okay, so they're all the happy patients. So the slightly unhappy patients. So this patient, the image on the left is a lytic spondylolisthesis. They presented with leg pain on the left and back pain. So the image in the middle is the post-surgical, which was a PLIF with an interbody fusion and pedicle screws. So immediately after the operation, the patient woke up, the left side of leg pain's gone, but now they've got right side of leg pain. So the first question is where are the screws? And you can see on the coronal CT, you can see that the L5 screw has gone into the canal and is impinging on the L5 root. So that screw was resighted, the leg pain went. So in a separate scenario, if the CT scan was normal, what would you do next? You do an MRI scan, and then you'd be looking for a hematoma, a collection. If that was normal, then you've excluded anything serious, and it's probably just going to be a neuropraxia, which will get better slowly. Okay, so this is anterior cervical surgery, 2-level corpectomy at C4-5 and C5-6, C4 and C5, sorry, for myelopathy. The patient did well a couple of days after the operation. Then 2 days later, developed a dense myelopathy, much worse than pre-surgical. So what do we do? First question, where's the metalwork? The CT scan was normal. Second question, is there a hematoma or a collection? And then you see the middle image is a T1 weighted, and you can see that anterior epidural hematoma, which you can see really easily despite all the metalwork, and that's compressing the cord at the proximal junction of the fusion. Just a quick word on an MRI scan. If you need to do an MRI scan straight after the operation, you can do it, it's fine. It's best to wait a couple of days, but we just do metal artifact reduction sequences, and you can see here we get really good images with not much artifact. You can see the canal, you can see the epidural space. This one's relatively easy if you've got both X-rays. So the X-ray on the left is immediately post-op, 2-level PLIF. 6 weeks later, comes back to clinic, said, oh, I've had back pain for 2 weeks. So the image on the right, you can obviously see that the interbody cage has slipped backwards into the canal. But if you were just looking at the X-ray on the right and it wasn't maybe an MSK radiologist, you didn't have the original X-rays, then you might think that that might be some form of spacer at the back. You know, hopefully not, but the importance here is just comparing X-rays. So the immediate post-op on the left and the 6 weeks clinic on the right, and that had to be revised. Okay, this is now 2 or 3 weeks down the line. This is a patient who had a interbody fusion at 4-5 and a big laminectomy at the back, and then presents 2 or 3 weeks later with pus draining out of the wound at the back, cellulitis over the skin, obvious superficial collection. So the point of the MRI scan is we know there's a superficial infection, but is there a deeper infection? Does the infection go down to the laminotomy site? Is there a discitis? Is there an epidural abscess? And what the MRI scan shows is that there is a superficial collection, but there's also a deep collection and a spondylodiscitis as well. So this patient was taken back to theatre, had the collection surgically drained, had the metalwork removed, and did very well. And in the end, ended up auto-fusing from the discitis a year later. So it was actually the same result as the intended plan of the operation, just in a slightly left field way. This is 6 weeks down the line. So the image on the left is immediate post-op. The image second from left is 6 weeks later, complaining of pain. And you can see that the S1 M plate implant has subsided. Now this may be non-infected or infected, but the history is 2 weeks, just gradual onset of pain, not quite right. Now, the MRI scan on the right shows, you get pretty good pictures. It shows some prevertebral soft tissue, and it shows signal changes in the adjacent M plates. Now, if this was done 3 days after the operation, this would be probably normal, because remember, it's an anterior approach, normally done by a vascular surgeon, so you will get soft tissue. You traumatize the M plates as well. Okay, but this is not a normal MRI scan 3 months down the line. So this was revised. I think I'm just coming up to the end. Just later complications. This is 2 years down the line, which shows a pseudoarthrosis of both levels. The image on the right shows fractures of the rods. And we'll just move on. So in summary, routine post-op plain films. You'll probably just see 3 plain films, no need for cross-sectional imaging. Post-op complications, whereas the metalwork you need to do a CT, soft tissue or collection or infection, MRI scan. Pseudoarthrosis, remember, a year down the line plus plain films, CT or SPECT CT. And then for adjacent level degenerate changes, basically plain films and MRI scan. Thank you.
Next, we've got Dr. Justin Lee, who's going to talk about the grading system, BA versus UEFA, so a subject that's dear to all of our hearts and minds.
Right, thank you very much. No financial disclosure. I've been involved in 2 grading systems for muscle injury. The first grading system that I was involved in was part of the UEFA Champions League ECIS study with Jerry Healy and Professor Ekstrand. And you can see that there was one important football club and then a series of lesser football clubs, the important one being on the left. And what would happen is that every time any of the players in that club, it didn't have to be a Champions League game, during their season had a hamstring injury or a thigh injury in general, they would send an MRI to the pair of us, and we would fill in a form on Paxmail, send it back. The data was collected by Professor Ekstrand, and we're essentially looking at MRI grading versus clinical outcome. And we did collect a very large number of patients. By the end of it, it was the largest series of thigh injury MRIs that have been published. So we used, to grade the injuries, we used the modification of the Petron's criteria. I'll talk a little bit about Petron's criteria later on, but essentially it was written in 2002, and it was an ultrasound classification, but he described a 4 grading system, including grade 0 being no macroscopic injury, and then grade 1 was, we decided that it would be edema, but no macroscopic architectural distortion of the muscle on the scan, and at grade 2 there was some architectural distortion, but not complete muscle rupture, which would put it into grade 3. So this would be a typical grade 1 injury, where you have feathery high signal along the muscle tendon junction would be the classic description, but no macroscopic distortion of the muscle or the tendon. This is a grade 2 injury where you're starting to see a little bit of possible detension of the tendon and some macroscopic distortion of the muscle. We didn't specify whether it was muscle or whether it was intramuscular tendon, and I'll talk about that in the next few minutes. So if we put all of these injuries together, the important thing, there were a few really important things that came out of this study, I think. One of them is that the majority of injuries in footballers are either normal or grade 1, so grade 0 or grade 1. And they don't have macroscopic architectural distortion. I have heard people say that actually what that means is they have normal MRI. That's not true. They have either a normal MRI, which is quite a small group, or they're grade 1 injuries. Now, a grade 1 and a grade 2 injury on UEFA is there macroscopic distortion? And actually, the difference between the two grades was not that great. Where it matters is when you get to a grade 3 injury. So if you have a significant rupture of the muscle, so you can see here, this is days of absence from play. And this is the hamstrings and quadriceps together. You can separate out the hamstrings and quadriceps and you get the same graph. Now, what we did pick up on this is the involvement of the free tendon. This unfortunately wasn't published in the paper that came out, the 2 subsequent papers came out, but we were already beginning to get a feel for the fact that if you damage the free tendon, the players do much worse. And you can see here on this graph that if there's damage of the free tendon, you double the rehabilitation time. So it was, it was a great set of data, and it was great to be part of this project because a lot of things were said prior to this paper that weren't really based in really good evidence. So the largest series up until this point, I think, was 17 elite athlete MRIs. So we then ended up with 518 at this particular point. And the things that some of the myths we sort of broke down at that time were, where it is in the muscle. Is it myofascial? Is it musculotendinous? And actually, in our group, if you're not specifically looking at the intramuscular tendon and you just look at myofascial musculotendinous, it actually doesn't make a great deal of difference. Similarly, various data, proximal, middle, distal, a paper was around for a long time, so distals do much worse. Well, not in our data. So that kind of, got rid of that particular theory. So you can see now, this was the published data, it was 516, sorry, not 518, and 70% were grade 0 or grade 1. So you can see that it's very interesting with footballers because they do get obsessed with it where they've got a grade 2 injury, and I'll talk again about that in just a second. But the grade 1 and grade 2 in our study didn't make a great deal of difference. The grade 2 to grade 3 is where it really matters. So moving on from UEFA, we went to the British Athletics System, which was really devised by Noel and Rob, who were speaking yesterday, and the 2 radiologists, myself and Steve James from the Midlands, who contributed. But really, this was driven by Noel and Rob, who's now at England. And there was a 5-point grading system, 0 to 4, determined by cranial length and cross-section of edema, and whether there's tendon involvement. They then introduced the suffix. So my personal take on this is that if you can't remember whether it's an A, B, or C, an A is away from the tendon. So that's a myofascial injury. B is at the muscle tendon junction, but the tendon itself is fine. And C is when you get intratendinous involvement. Now, I'm not going to go through in detail because we haven't got enough time, but essentially the criteria you're looking for is what's the length of the edema? How much is it in cross-section? And is the tendon normal? So as you go up on all of those numbers, you start going up grade per grade. This particular picture is controversial because the classic site of a myofascial injury is the long head, short head, and recent paper by David Connell has shown that that's not a myofascial junction, that's a musculotendinous junction, and I definitely agree with that. So as we move to grade 3C, grade 2C here, it says no loss of tension. I must say this is the image that was in the paper, and I would argue that there probably is a bit of loss of tension in that image, but essentially you should not be seeing a loss of tension. And grade 3C, here this is an athlete, one of Noel's athletes, and they're starting to see loss of tension. But when you do a fine-cut MRI, and I have to say, one of the problems with the UEFA study is that a lot of the images we had were not brilliant, and we weren't able to get to this detail, but now we are. So the key thing is the 3C. 3C is the key. If you have a 3C injury, your return to play time will completely go through the roof. Similarly, your re-injury rate will go through the roof. So who wins? Should we do UEFA or should we do BA? Well, UEFA wins on huge numbers, okay? There's a clear relationship between your UEFA grade and your return to play. But does BA win? Because BA has now identified that 3C is the key. So if there is an intramuscular tendon injury, you need to report that. But part 1, this publication came out last week online, and it was an interesting study because it suggests that the intramuscular tendon injury is not significant. I would argue otherwise, and I think there'll be a lot of commentary on this as time goes on. But this is from the Qatari group. They excluded some key injuries. Have a read of it. It's in the BJSM. But the second and probably more important problem I have with the BA system is, are we ready as, not necessarily us, but are we ready for a fundamental change in reclassifying muscle injuries? Because everyone in this room will be familiar with the British athletics system if they're involved in players and athletes, and that's fine. But the problem is not us. The problem is the players, the manager, and the agent. And if a player is told he has a grade 2 injury because his muscle edema is 5.5 centimetres, for him it's a disaster. For the manager, it's, oh, it's grade 2 injury. So that, I think, is the biggest challenge. Now, we can educate. We were talking about this again yesterday with Noel. It's about education. Well, you know, everyone in this room is here to be educated, but I doubt there's any professional footballers, football managers, and agents in this room. So in summary, the UEFA system is familiar to the player, agent, manager, and the medical team. The BA system is only really familiar to us at the moment. So should we report both grades in each report? I do, a lot of the time. Should we grade at all? One of our clubs doesn't want to grade, which is quite an interesting concept. Please don't grade it. Don't do it. Fine. So my tip is ask your referring physician team what they want, and in equivocal cases, use both systems. Thank you very much.
Next speaker is Dr. Phil Robinson from Leeds, who's going to talk about imaging the pelvis, hip or groin. Many thanks.
Thank you. So we're going to start with groin, and we're going to talk about long-standing groin pain. And if we look at the anatomy in the region, it's quite complex. It's not discrete attachments. It's, as you can see here, a number of tendons attaching to the capsule, the soft tissues, and the symphysis pubis, and quite often blending. And within that, there's even a lot of normal variation. So what do we know about groin pain? Well, we're not talking about acute groin pain, acute tears. We're talking about more long-standing groin pain. And we know that the diagnostic terminology, both clinically and in the literature, is hugely confusing. People call it enthesopathy, osteitis pubis, sportsman's hernia. And that was why there was a consensus group in Doha a couple of years ago that tried to define it clinically, not radiologically, but clinically. And they had 4 main groups, and subsequent studies to that, recently published this year, have shown that the commonest clinical area, certainly in footballers, is what's termed adductor-related pain. So what do we know from an imaging point of view? Well, there aren't that many studies. The majority are MRI, and only 4 of them have measured inter-observer reliability. Certainly, if you look at ultrasound, the evidence is even less clear and less good. And really, I'm going to exclude ultrasound from the majority of this talk because the evidence isn't there, and the features in the inguinal canal are more confusing than helpful. So if you look in the literature, there are 4 main radiological findings described around the symphysis pubis, which is the main area that we see abnormality on MRI. But we can simplify that because we know that degenerative changes, spurs, and so on, occur normally in the population, but certainly occur normally in the athletic population. And we're really left with 2 main findings, and that's bone marrow edema in the symphysis pubis and edema in the soft tissues involving the capsule and the surrounding tendons. And the problem we have is that these findings can occur normally in athletes. And really, it's the intensity that seems to be more important in these 2 areas to correlate well with the clinical findings. So Steve Eustace's group described the cleft, as which you can see here, and it's an extension of the primary area of the joint, and they described it as a cleft because they were actually seeing it indirectly when they were doing injections fluoroscopically and seeing the leak. And all it really is not really, I wouldn't say it's a cleft per se, I would say it's more a detachment of the capsule and the surrounding tendons at this point, and this can be partial or complete. And we can see it on the coronal, again, as you can see here, and also on the oblique axial sections. And again, they found a high correlation with the side of symptoms and said this was, in fact, the most specific finding you can see. Unfortunately, it isn't that specific, and more studies have come out in the last few years. And certainly in football players normally have bone marrow edema in their pubis. They can have a cleft, which is not unsurprising because if you have a partial disruption or a full disruption in any soft tissue around the body, you quite often don't get complete healing. You may have granulation tissue, you may have fibrous tissue that's high signal on MRI, and you can see here this is an asymptomatic individual and they've still got a left-sided cleft. So it seems to be that the intensity of the bone marrow edema, and if you do have soft tissue disruption, the surrounding soft tissue edema seems to be the most important things to define on your imaging, and that correlates better with the clinical findings. And as I've said, ultrasound of the inguinal canal looking for bulges and so on is really not that helpful. So let's move on to the hip. And what do we know about the hip? Well, again, there's a huge vogue for cam and pincer impingement. But again, a number of studies are now showing that these osseous findings, both on X-ray and CT, are completely, can occur in asymptomatic individuals. And the study quoted here has over 2,000 subjects who are all asymptomatic and all had, 10 to 20% of them had cam or pincer associated abnormalities. Now, we don't know if they go on to develop impingement in the long run, but at the moment there's a huge amount of data showing that these findings must be correlated with the clinical examination, which of course is very important. So really from an imaging point of view, we're more interested in looking at the soft tissues, be that the labrum, the cartilage, and the surrounding soft tissues. So from an imaging choice, if you look in the literature again, it would still say that MR arthrography is the most sensitive and specific technique. But again, that is relatively historic. That's talking about studies from the late 90s and 2000s. And MRI technology has massively changed with the advent of 3T. We also know in the hip particularly, compared to other joints, you don't get good distension or good coating with arthrography. And a number of studies are looking at 3T on its own as opposed to MR arthrography. We've just published a study in European Radiology where we looked at 60 patients who had both tests, and we actually found that 3T without arthrography was just as good for the labrum, but more important clinically is that it was superior for cartilage. And in fact, the only difference between the two groups was that the patients with more symptoms went on to surgery. There was no difference in their imaging findings. So if you're performing 3T, the high resolution it offers allows really good imaging, but also you can do additional imaging, and I would advocate doing radial reconstructions. And this allows you to move away from the typical coronal and sagittal planes and sample the labrum and the cartilage in the interval between them. So you can see here, if we go through this area, we can produce an image that shows the labral defect and normal cartilage. And here we have a coronal PD-weighted sequence, and it looks pretty normal. If we go to the sagittal sequence, we see the labral tear. And again, this is extremely common in asymptomatic athletes, and then more and more studies are showing this, that labral tears are quite often an incidental finding, and certainly labral degenerative change in athletes is really common. And the cartilage seems to be more important. And if we look here, the cartilage looks normal, but if we go to one of the radial images, we can then see the start of the delamination, and that's a crucial thing to define for the surgeon and for the athlete so they get the right treatment. So in conclusion, if we look at the groin, certainly spurring, irregularity, disc extrusion, and assessment of the inguinal canal on imaging isn't that rewarding. When we look at MRI, certainly bone marrow edema and capsular and adductor soft tissue edema seems to be the two main areas to define, but can be seen in asymptomatic individuals. So it's the intensity and the surrounding soft tissue change. When we look at the hip, I think now that MR arthrography is not routinely needed. 3T allows you better assessment of the labrum, but more crucially, the cartilage, given the number of asymptomatics. If still you can't define what's going on, you can use injection for putting diagnostic injections either into the symphysis pubis using ultrasound. Of course, you can do fluoroscopic injections into the hip or ultrasound itself. Thank you.
We move on now to Dr. Gajan Rajeswaren, who's going to talk to us about MRI sequences. Which ones?
Thank you very much. I have no disclosures. So the objectives of this session are to look at how MRI works, very briefly, and the types of MRI sequence that we use in musculoskeletal imaging. And we'll go through a case example to try and demonstrate how we use deduction to make the diagnosis. How MRI works is that we have within our body hydrogen protons. It harnesses the power of hydrogen protons, which are little mini magnets within the body. And when we put a patient in a magnetic field, all those mini magnets, the hydrogen protons, align along the longitudinal axis of the magnet, all spinning in a process called precession. If we then pop some energy through the patient by firing in a radiofrequency pulse, those magnets are thrown out of alignment, and then when we take away the pulse, they then slowly return back to that alignment in the magnet. And that process of going back to normal alignment is called relaxation. Different tissues, depending on their hydrogen content, will relax at different times. And by looking at that, we can work out, using computer analysis, the composition of tissue within the body and work out what's going on in terms of anatomy. By varying the time that we take to look, the frequency of the radio frequency pulse, and also the strength of the magnet that we put the patient in and the gradient of the magnet, we can get pulse sequences that are variable, that look at different types of tissue contrast. And the European Society of Skeletal Radiology sat down as a committee and came up with a kind of dream team of sequences that if a patient has a sporting problem, what would be the best things that we could see. And this is that dream team. But what you will find is when you see your patients, there's massive variation. And that's because different scanners will have different ways of scanning, different institutions will want to scan patients at different times, and therefore the quality may be different. But you will find also that depending on what the clinical indication is, that the protocols will differ. So what we're going to talk about is the common stuff that we see in musculoskeletal imaging. So this is a T1 weighted sequence. So what is the T1 weighted sequence and what does it show? Well, the first thing to say is that everything, when I talk about bright or dark, is reference to the skeletal muscle, which is kind of an intermediate grey color. If we look at the fluid in the suprapatellar pouch, we can see that it's dark. And the downside of a T1 weighted sequence is that fluid is dark, and our brain tends to see bright things well. So T1 weighted sequences are not good at looking at cartilage because the fluid and the cartilage don't contrast well against each other. But where T1 weighted sequences are good is looking at anatomy. And here you can see very nicely a fracture at the posterolateral aspect of the lateral tibial plateau in a patient with an ACL injury. T1 weighted sequences are also really good at looking at marrow infiltration. So for me, it's a go-to sequence for bone tumors. Here's an example of an expansile lesion in an adolescent athlete, which was an incidental finding. This is an aneurysmal bone cyst. The other important thing to note on T1 is that there are certain things that are bright, and knowing that can help you work out what's going on in terms of the pathology you see. The most common things being fat, blood, proteinaceous fluid, and in the context of having given contrast, gadolinium contrast. The PD sequence is a workhorse sequence that we use in musculoskeletal imaging, and most of the sequences you will see will have a proton density sequence in there. And the difference from a T1 is that you can see that the fluid is now bright. And the beauty of that is that you can then contrast beautifully against the cartilage. Because it's an intermediate sequence, it's not completely T2, we still retain a lot of the anatomy that we want to see, but we can now demonstrate very nicely that there's a full thickness cartilage defect, which we would probably find difficult to see on a T1 weighted sequence. And then the other common sequence that we look at is fat-saturated sequences. So this is exactly the same sequence as the sequence I just showed you. It's a proton density sequence. The only difference on this study is that the fat signal has been saturated, so it's dark rather than bright. And the beauty of that is that because pathology tends to be full of fluid, we can contrast out that fluid because the only thing that really is bright is fluid signal or cellular signal. And here you can see that edema within the bone in this femoral stress fracture is very easy to see. Had this not been a fat-saturated sequence, the marrow in the bone would have been bright, and it would have been tough to see that bone marrow edema. So the fluid-sensitive sequence is a kind of money sequence to look at. If you're with a patient, that's the one to go to first to look for pathology. And then we look at the stir sequence. And what is the difference between a stir sequence and a conventional fat-saturated sequence? And that is that it's much more sensitive for looking at edema and fluid. So you can see in this calcaneum that there is a small interosseous ganglion, which on the equivalent region on this coronal fat-saturated proton density sequence is much more difficult to see. So it's very sensitive for edema, and we tend to use it in trauma and infection. The downside of it is it's much poorer at looking at cartilage compared to proton density sequences. The remainder of the talk looking at a case example to try and work out what's going on and demonstrate to you some of these findings that we show. So this is a fat-saturated proton density sequence, one of our workhorse MSK sequences. The only thing that's bright will be fluid, and pathology tends to be bright and shows some fluid. So if we focus on the patient's left, we can see that there is some fluid on the lateral aspect of the thigh. As we come through the patient's thigh, we can see that there's a very well-circumscribed lesion. This patient was an athlete that fell during competition and landed on the ground and presented with a painful swelling. We can see that this lesion is very well circumscribed. It's in the region of the deep fascia, and it's pushing away the musculature adjacent to it. It's relatively bright, and it's relatively homogeneously bright, but there are bits that are slightly darker within it. So because this is a proton density sequence, we can make a conclusion that this is likely to be a very cellular thing, either a tumor or it's going to be fluid. So can we then look at the other sequences to figure out what's going on? So we're now going to look at a T1 weighted sequence, and the difference with the T1 weighted sequence is fluid is dark. Okay? So if we look at this, we just about catch the bladder, bottom of the bladder here, we can see that's very dark, and that's what typical fluid looks like. So if we now come and find this lesion on MRI, we can see that at the same area where it was very bright on the fat-saturated proton density sequence, it's still bright on the T1 weighted sequence. And we said that bright things on T1 can be blood, proteinaceous fluid, contrast if we've given contrast, and fat. In this context, we know that it was bright on the fat-saturated sequence, therefore it can't be fat, because fat would have been dark on that sequence, and therefore we can say, given the trauma, that this is going to be a hematoma. So with that, I'd like to finish, and thank you very much for your time.
The next speaker is Dr. Jerry Healy, one of the Fortis radiologists. He's going to be talking about the difference of using a 1.5 Tesla versus a 3 Tesla MRI unit in musculoskeletal imaging.
Thank you. I've got no disclosures. I will discuss the benefits and disadvantages of each field strength and compare the performance in the knee, hip, shoulder and wrist. 3T has increased signal to noise, allowing decreased acquisition time, increased spatial resolution or both. It also reduces partial volume artifacts using thinner slices and no gap. However, there are increased artifacts related to metal wear and also to magnetic shielding, and also there may be some increased radiofrequency field inhomogeneity. All these things may degrade the image. This is a susceptibility artifact from a hip replacement at 3T, severely degrading the image in comparison to 1.5, where we've got better metal artifact suppression. In the talk, I have to address the following questions. Is there increased diagnostic performance using 3T versus 1.5? Is there a clinical benefit of 3T over 1.5? I'm going to start with the knee. Van Dijk published a level 1 study in JBJS in 2013 comparing 1.5T and 3T in 200 symptomatic patients for meniscal and ACL pathology, 100 of whom had arthroscopy. Their conclusions was that routine 3T did not significantly improve the diagnostic performance for evaluating knee menisci and ACL tears compared to similar protocols at 1.5. They also performed a prospective study in 100 patients, all of whom had 1.5T, 3T and arthroscopy for cartilage injury. They showed that 3T had a statistically significant higher sensitivity for the detection of cartilage lesions in symptomatic patients when compared to 1.5, but a significant number of cartilage lesions will still remain undetected at 3T. 3T was better than 1.5 in correctly grading cartilage lesions, and they concluded that 3T had better diagnostic performance for detecting cartilage lesions in the knee. This slide shows a patient with an arthroscopically confirmed grade 2 cartilage lesion on the medial tibial plateau, not picked up at 1.5, but 3T shows a definite partial thickness fissure. There's also blunting of the menisci in both scans caused by a radial tear confirmed with arthroscopy. This slide shows a patient with normal cartilage arthroscopically. 1.5T reported a grade 2 cartilage fissure. 3T correctly reported the cartilage as normal. An oblique tear is shown by the arrowheads. Now, this is all very well, but has 3T improved diagnostic performance versus 1.5 for cartilage injury? Does this have a clinical impact? Mandel compared diagnostic performance of clinical MRI reports for the assessment of cartilage 1.5T and 3T compared to arthroscopy in almost 300 patients and found no significant difference in the diagnostic performance between the two field strengths. Moving on to the hip, a preliminary study in 2006 in 8 patients, and I can't reference my former speaker's talk, showed 8 patients with arthroscopic correlation showed that 3T was better for chondral injuries and equal for labral tears when compared to 1.5 MR arthrography. A larger study published in 2017 confirmed the accuracy of 3T versus arthroscopy in identifying labral and cartilage injury in 42 patients with FLI. In 2014, Chan and colleagues showed that 3T MR arthrography had a better diagnostic performance than conventional 3T for diagnosing labral tears using arthroscopy as a gold standard. And these images show that 3T more elegantly defines tears in the superior labrum, including contrast going into a paralabral cyst. It also allows the application or injection of local anesthetic, which is frequently used as a diagnostic test by our clinical colleagues. Moving on to the shoulder, I could find no studies comparing 1.5 and 3T. However, McGee posed the question, was arthrography still necessary at 3T? He looked at 150 consecutive cases. They had 3T arthrography and arthroscopy. MR significantly improved the sensitivity for partial articular surface supraspinatus tears, anterior labral tears and slap tears compared to conventional 3T. It also showed superior sensitivity for full-thickness supraspinatus tendon tears and posterior labral tears, but these results did not reach statistical significance. So this patient shows no labral tear on conventional 3T, but an ALPSA lesion is shown on MR arthrography, confirmed arthroscopically. MR arthrography has been reported to be more sensitive in detecting unstable tears, which may be helpful in selecting patients for surgery. This patient with shoulder pain appears to have an intact but tendinopathic supraspinatus tendon on 3T images, but arthrography, there's shown to be a high-grade articular surface partial tear confirmed arthroscopically. The literature suggests that 3T MRI may mistake fibrosis as an intact tendinopathic tendon. Moving on now to the wrist, this is a clinical study from Anderson and colleagues, and they reviewed retrospectively 102 patients with on-the-sided wrist pain. Their results show that 3T is better than 1.5T for TFCC injuries and performed better at identifying scapholunate on the triquetral and lunotriquetral ligament tears. They concluded overall that 3T had a better diagnostic performance than 1.5. A paper by Zan and colleagues published this year online confirms that 3T is very good at looking at TFCC injuries in 86 patients, and they were confirmed surgically, and even identical injuries not included in the Palmer classification, such as a horizontal tear in the articular disc, which does not extend to the joint surface, and a volar capsular TFC detachment at the edge of the articular disc. Again, McGee compared 49 patients who had 3T MRI, 3T MR arthrography for intrinsic ligaments and TFCC tears correlated with arthroscopy. 3T MRI is specific for the detection of TFCC and ligament tears, but MRI had 100% sensitivity. So concluding that 3T MR arthrography again had a better diagnostic performance than 3T for TFCC and ligament tears. This patient has a scapholunate tear shown on MR arthrography, but missed on conventional 3T and confirmed at arthroscopy. So it's important to realize that both 1.5 and 3T images are continuing to improve. This is due to optimized imaging protocols, reduced energy deposition, and reduced artifacts. Optimized coil and hardware design, which have combined with parallel imaging, allow faster acquisitions both at 1.5 and 3T, which means thinner sections, high in-plane spatial resolution, and better visualization of anatomy and pathology. So to conclude, is 3T better than 1.5 in MSK imaging? Well, it better delineates subtle focal cartilage lesions. It better delineates small intra-articular structures such as the labrum and intrinsic ligaments. 3T does improve diagnostic performance, particularly in the hip and wrist. Its clinical benefit is less clear, particularly in the knee. It is also important to emphasize that MR arthrography continues to improve the diagnostic performance at 3T, and at present, metal artifact suppression is better at 1.5 than 3T. Thank you.
Thank you very much, Jerry. The next speaker is Dr. Richard Hughes, and Richard is one of our Fortis radiologists. Again, he's going to be discussing ultrasound versus MRI.
Thanks very much. Good morning, everybody. I have no disclosures. I'm going to just run through in the next few minutes ultrasound and MRI. Both these modalities have been around since the sort of late 70s. I'm going through various technical and various innovations in the meantime. And they're partly competing modalities, but also I hope I can show that they can be a complementary tool looking at patients. Now, we know that MRI is a very robust modality for bone marrow, for cartilage, tendons, ligaments, and muscles, as we've just seen in some of the other talks. The acquisition protocols can be standardized. You've got a really readily transferable data set. And the really nice thing about MRI is you can compare over time, and in between radiologists and clinicians, everybody can look at the same images. And intra-observer measurements tend to be fairly robust. Disadvantages are patients don't like going on an MRI much, or at least some patients don't. There's various contraindications, such as pacemakers and metal implants. The magnets themselves tend to be really expensive, so £1 million or so to install one of these. And you get artifacts, particularly with the nervous patients and around surgical hardware. And sometimes we've got to use gadolinium, and we'll hear about that, but that's becoming a little bit less fashionable. MRI is a great modality for tendons, for ligaments and for muscles. The resolution of MSK ultrasound is about 200 micrometers, which performs about 2.5 times better than MRI. And things like these little linear calcifications you start to see really nicely on ultrasound. You can use dynamic assessments, you can move the joint, you can use it to guide a treatment. And really, ultrasound is becoming an extension of the bedside examination. There's lots of our clinicians that I work with that use ultrasound very effectively for diagnosis and for treatment. And there's lots of examples of clinician-led ultrasound in various areas, not just MSK. It's a robust modality for soft tissues. You can turn on the colour flow and get some physiological information, which is hard to do with MRI. So things like this Achilles tendon, you can see the extent of neovascularity very nicely. In rheumatology, you can look for inflammatory synovitis and erosions. And these machines these days are portable, they're easy to use, and clinicians can get good at this very quickly. Disadvantages is that it's a bit of a wild west out there, and the operator dependency is a big flaw of ultrasound, and experience and appropriate training seems to be key in accuracy. The data set's a bit hard to review temporarily because the next sonography you see might be a different machine, different person, and that causes problems in following structures up if it's not the same radiologist. Deeper tissues are a bit more of a challenge, and there's blind spots in bone and in joints. An artifact is much less of an issue. The limited evidence that there is looking at MRI versus ultrasound for ligament and tendon pathology show that they're probably equivalent. So the accuracies seem pretty good, with probably the sort of footnote that these are usually experienced operators in these studies. There's more variable factors, as I've alluded to, but it's worth just pointing out that kappa values in MRI aren't perfect, and there's a small amount of literature showing that, that these can be equivalent. So when should you use ultrasound? Well, there's a few key areas where ultrasound is clearly the better test, looking for foreign bodies, as in this splinter. You can see these exquisitely well on ultrasound, pretty hard to see on MRI. And you can see the granuloma. You can mark the skin for the plastic surgeon. You can fish these out yourself, but from experience, I'd recommend you do that early rather than waiting for the granuloma to form. Peripheral nerves are seen really nicely on ultrasound because of the resolution. And you can see the individual fascicles in a nerve, which is hard to do in MRI, but not impossible. You can image the whole limb rapidly, so you can look at an ulnar nerve from the upper arm down to the wrist in radius of a few seconds. And you can then block the nerve or use ultrasound to guide the treatment. You can look at nerve pathology, such as this nerve sheath tumour, and you can see the nerve fascicles coming into this nerve sheath tumour really very nicely, also seen in MRI. My blood pressure wouldn't stand putting a video in, so this is from the literature to show dynamic imaging. So if you move this, the perineal tendons from this paper by John Jacobson, you can see the retinaculum distracts and the peroneus brevis dislocates around the fibula. Again, can't do that with MRI. Ultrasound's really nice. And a muscle hernia in a young athlete, when you dynamically stress them, you can see the little muscle hernia coming through very nicely. Ultrasound's also the test of choice around surgical hardware. This is a pseudotumor around a Birmingham hip replacement, and you can easily use ultrasound again to access this if you need to sample it. This is a patient I saw recently, just last week. Resolution isn't brilliant, but she had extensor compartment tenosynovitis. And this little echogenic thing just poking out from the distal aspect of the radius was actually from a volar plate fixation and secondary tenosynovitis. And an MRI, this would look like a bomb had gone off. There'd just be lots of artifact. Ultrasound's also useful if you want to tell if something's cystic or solid. MRI can fall down with these. You want to give gadolinium, which again, as I've alluded to, isn't always a brilliant idea. And again, we can stick a needle in when we've got the ultrasound scanner by the patient. You can identify the swollen bit of the tendon and the inflamed bit of the tendon, the neovascularity, and you can pick your substances. We've heard lots about those yesterday. And then we can use the ultrasound to guide the needle into the sweet spot. Ultrasound's not great for bone, but it's not terrible. This is a patient I saw fairly recently with some metatarsalgia looking for a Morton's neuroma. There's no sign of that, but we did see this subarticular collapse and joint effusion at the second metatarsal head. And this was Freiberg's disease, pretty easily seen on ultrasound. Where MRI is the investigation of choice, well, certainly for spinal imaging, ultrasound's no good. Large joint mechanical derangement, that's where you want MRI. Bone and bone marrow, obviously we get no information on with ultrasound. Articular cartilage. And the last point I made, sports muscle injury, which we've heard quite a lot about. And ultrasound is really high resolution, and lots of you and lots of us are using this very usefully. Extended field of view is really nice, as in this gastrocnemius. You can see the detail of the tendon and the gap really very nicely. But as Justin alluded to, some of the modern classification systems, ultrasound doesn't perform quite as well on. You can't see muscular edema terribly well with ultrasound. If a tendon is completely detached, there's a large hematoma, it can be really very challenging to pick the tendon out of that. And MRI is a standardized test, certainly in elite athletes, to classify these injuries at the moment. But ultrasound certainly has a role and is being used usefully. I think it was Justin that told me that if you're wondering about ultrasound or MRI, the key test to ask the patient is, where does it hurt? And if the patient points there and says it hurts there, ultrasound may have some benefit to have a look at that. If you ask them when it hurts and they're waving at the whole limb, ultrasound's a bit more tedious, less likely to be fruitful, and MRI may be your best choice then. So in summary, I hope I've showed that MRI and ultrasound are complementary tools. Ultrasound's got a clear advantages. There's metalwork if you're looking for foreign bodies or assessing a nerve, synovitis if you want to see something move dynamically, and to guide interventions. Both modalities do have roles in tendon and soft tissue injury, and MRI is certainly the better test for assessing large joints and for bone marrow and articular cartilage. Thanks very much, everyone.
Next up, we've got Dr. Kesthra Satchithananda, who's done tons and tons of work on the joint replacement and issues that you can get around joint replacement.
I've got nothing to declare except for the fact that my talk is all about how a bomb goes off when we image a metal implant on MRI. And to be fair, not very long ago, certainly in my time when I was training, that is probably how metal artifact and MRI scans would look if you asked us to look at a post-operative MRI scan. However, when you ask a radiologist, that's what we see when you put metal in, and that's what we never want to see. So when I put that in as a joke, but also because we've had a reasonable amount of referrals for people to image their prosthesis or post-operative joints because their local hospital says you'll break my MRI, and that really won't happen unless you do something like that. So there are some very general principles that we teach everyone when we are protocolling, and the important thing for us to know is that we need to protocol. There's lots of things that we can use to try and make sure that the metal artifact is reduced to a minimum so that we can get a diagnostic study to be able to answer the questions that we need to answer. Is it perfect? No. Will we get rid of all the artifact? Absolutely not. But in more modern times and with the help of manufacturers, that has got inordinately better. So we started off with the physicists working on what we didn't want to see to get it to be more like what we wanted to see in these phantom works. And when we then looked at what we could do, we then had to look at the answers of the questions that we would be asked to image. And in fact, what we normally would be asked to look at is loosening, whether it be septic or aseptic, soft tissue lesions around the prosthesis, particularly around the metal-on-metal hip work that I've done with Adam, and that was a kind introduction, so thank you. Looking at internal derangements after post-operative symptoms, and also looking at some of the peripheral soft tissues that may help in conversation, counselling patients prior to any further therapies, and also in trying to give us a heads up on what the success rate of rehabilitation will be. So there's just a lot of images just showing that maybe we don't have a bomb going off and that we can see the things that we see. On your left there, we have a sagittal fat sat image looking at an ACL reconstruction. You can see some of the artifact from the surgical intervention, but also you can see some of the marrow signal that within the proximal tibia. I've put a coronal T1 image on the right side because it's to show there is an ACL reconstruction there. You can see the tunnel coming through, but it also gives us a good way of looking at the osteophytes and the degree of degenerative changes, which is increasingly what we're being asked to look at. And you would have heard from Dr. Fiona Watch yesterday and some of the stuff that we're doing with cartilage imaging after injury in young patients to try and predict degenerative changes against biomarkers. Those are the sort of things that we are wanting to look at. We follow metal artifact through on sequences. I, like Richard, don't have a blood pressure that can put up with video loops, so you're having static images too. And you're looking to look at the soft tissues. You can see the patellar tendon there with that axial imaging through the proximal tibia and fibula. And we can follow the artifact through through to look at the intercondylar notch and up into the femur. And the things that I want to say is that we can see an awful lot of anatomy and pathology on these stir sequences, including the quality of the cartilage, including the quality of the ligaments and also the metalwork. This is probably most of the work that I've done up till now, which is looking at these hip prostheses and looking for the soft tissue pseudotumors after the MHRA alert a few years ago. It allows us to look where these soft tissue collections that you can see here posteriorly in the joint with debris, and as Gajan said very clearly, eloquently in his talk, this is telling us where there is synovial or hematoma or metal artifact, and we can see very clearly the capsule and the prosthesis, and you can see on this resurfacing the stem. So going on to seeing, again, more of the same, but I just wanted to let you know, to sort of point out how much we can see around the muscles. We can look at the bone, and we can look at the prosthesis itself and try and get a three-dimensional view on what we want to see and actually see how and where it communicates with the joint. So more distal metal artifacts, so we're interested in the knee, and that was the question, but you can also see how we can have metal and it not disturb or distract from the questions asked. And sometimes when it's on the periphery, we can have really exquisite detail on some of the anchors that are used. So we can also look at the soft tissues around. Here we have the prosthesis, and we can look for marrow changes and the loosening around these prostheses. We look at the hip abductors because we know that that is something that's important as far as rehabilitation and discussion with patients should they have to have revision surgery. And we look in multiple planes, and we can look at different parts of the gluteus medius muscle here, the anterior and the posterolateral structures, and know that there is a differential in the way that the fatty atrophy has happened. All the manufacturers are working with us in improving our sequencing and our imaging of these post-surgical metal artifacts. They've all got fantastically stupid and unbelievably illogical names, but they're there, and the issue is that they basically use all of those principles on that earlier slide of how to get rid of as much of the artifact as we can. When we don't do so well is absolutely very close to the prosthesis, and that's where I think the ultrasound really does come in. We can't always tell on MRI if it's an infected or an aseptic loosening, and so we would use other imaging modalities, and prosthesis positioning is not very well done, and I think a CT scan with a multi-detector is a much better option. So in summary, I hope that we see that imaging of metal after into a joint is diagnostic, and it is getting better even at higher field strengths. I think the key is that clinico-radiology communication, knowing what we are imaging, what's there before we start, and what the question is. Thank you.
Onwards and upwards. The first thing, it took us about 3 months to learn how to spell Miscellany. It's an incredibly hard word to spell, I promise you. So this is just a little collection of cases. We didn't really fit in anywhere, so we said, oh, well, let's put it in Miscellany, and then spent 3 months working out how to spell it. So we don't have any financial interest. Adam's going to start off looking at this first case.
Great, thanks a million. This is a real case, and it was the machine's broken. So we've got two sequences here that you can see, and now we're all very well educated about what the sequences are. When we were faced with these sequences, it was, so what are the sequences? We can't really make head and tail. We know that certainly there's a little bit of fluid in this sequence here, so it probably is some form of PD, whatever, but the marrow looks bizarre. And what the heck's going on here? You know, the marrow's all sorts of signal here. So we thought what we'd do is we'd look at what the settings were. It says PD, FAT-SAT, and T1. So the next thing we do, we go back to the radiographer and say, look, you know, something's gone wrong here. Somebody's pressed the wrong button. So this is what the actual sequences should look like there. You can see the marrow is very dark on the PD FAT-SAT, on the T1 it's very bright. So just to go through them again, we're set with these very unusual sequences. These are not uncommon. We're seeing this quite frequently now. This was a case we saw 2 weeks ago, almost the same case, almost the same signal characteristics. And this is a disease that we call serous atrophy. It's quite important to make this diagnosis because often the clinicians aren't quite aware of it. It's associated with cachexia, anorexia, HIV infection, malignancy, congestive cardiac failure, and myelodysplasia. So an important thing to see. The machine's broken, interesting, because of the cases reported, you can see that 7 patients underwent a repeat MRI scan due to misinterpretation as a technical error. So just beware. If it looks odd, it might be serous atrophy. Thank you.
Why do we exist? I have asked this question. This is the sort of question, the sort of comment we get to hear from people. I don't need a report. I look at my own images. Okay, fine. That's good. I think you should. We are disadvantaged. We get this fairness. We're disadvantaged because you don't see the patient. Well, that is undoubtedly true apart from an ultrasound. So what is our role in life? Yeah, it's a deep question. So here's a footballer. This is, he's got a 6-month history of back pain, not responding to physiotherapy, MRI lumbar spine. It's a pretty reasonable request. And you can see it's a fairly typical picture. He's a fairly young, athletic person, and he's got a spondylolisthesis at L5S1. He's got degenerate discs at L4-5 and L5S1. There's obviously an annular fissure. And so you can ride through, you can see that he's got pars abnormalities at that level. So here it is on the axial imaging. We're just running down, and we're going to get down to L5S1. And so that's his diagnosis. That's the problem, because if I go back up now, you'll see that he looks like he's got 3 vessels. He's got an aorta, a vena cava, and something else, but he hasn't. That's a lymph node. So this is his opportunity to make a diagnosis that he didn't know about. Adam's next.
Thanks very much. Next case, quite an interesting case. We see a lot of patients who have these so-called chondral lesions. We're missing some arrows here. Firstly, we can see actually there's a chondral fracture here. So the cartilage have just been avulsed. The next thing is where can it be? So we have a good look around the knee, and we can see that this little bit of cartilage is stuck at the back of the knee. And we sort of invented, well, I did, for the surgeons, that we call it the railroad sign. So if you're looking for bits of cartilage, it's black, and there's a sort of white bit in the middle. So it kind of looks a bit like a railway track. And this is it on the PD FATSAT. And we're zooming up there. So all very, very easy and straightforward. Hey, let's do another one here. Very important. You can see that. You can see the cartilage gap there. And there is the lesion at the front of the knee. Unfortunately, the report wasn't digested for this one. And the surgeon went in, because they go in through the knee, they didn't really appreciate that they were bypassed a bit of cartilage there. And it's quite a big bit of cartilage. Here's another one. So it's your turn. Can everyone see where the cartilage is? Yeah, good. Excellent, well done. And here it is again, zooming up there. So same bit again. Oops, that's actually a bit of fat. So what we've got to do is be very careful that we use our sequences and optimize our sequences to make sure we're looking at the correct thing rather than giving a patient an operation to remove some cartilage, which is actually a lump of fat. Thank you. Oh, final bit, just a little bit at the back there. Fat again.
43-year-old lady, chronic back pain, degree of degenerate disc disease, question mark. That's what's on the form. This is typical. And, obviously we're not seeing the patient. So just run through. Doesn't look too bad. In fact, looks pretty good. Just get to this point. It's like, hang on a sec. What's going on over here? That's a bit of an odd appearance. Have a look at the axials, running through. And I can tell you that it is easy when somebody's pointing to it, that in the middle of your reporting session, you're going to miss it if you're not looking. And that was not a bronchial carcinoma, but it was a hematoma of the lung. And I'm going to go back again later on just to finish off. Adam's next.
Knee pain in adolescents. We see a lot about adolescents with knee pain. Those 2 arrows have unfortunately been mistranslated. What we have here is a little bit of edema just around the growth plate, which is starting to fuse. We see this quite often. Normal knees, we see this. You can see actually it's on both sides and it sort of flares up north and south. There it is again. And on the T1s, you can actually see it as a slightly darker or lower signal intensity lesion. This is another one we saw last week. And we're seeing these quite frequently now, especially in the adolescents, and it's called focal periphyseal edema, or the FOPE lesion. So if you can't see anything in the knee and you see this lesion, then that's what the diagnosis is. And it's been well described in the literature, but it's something that maybe you're not aware of, so hopefully that's just drawn your attention to it. Key thing is not to miss this one, which is exactly the same, and that's a Brodie's abscess.
So finishing off, the relevance of incidental findings. So here is, you can use the scout view. Occasionally we don't get sent them, but actually there's something up there on the scout. And this thing is so obvious, I'm pointing at it, but I can tell you that when you're looking at the spine, it's tempting not to look at this stuff. That's an adrenal tumour. And actually, when it's over 4 centimetres, there's a 1 in 4 chance it's a cancer. So if we did a look at what's published, there's actually an incidental finding rate of up to 24%. It's higher on CT, about 13%. So it's about 1 in 8. Madam, you're a math genius. About 1 in 8 of your MRIs will have an incidental finding. And those findings range from minor to major pathologies, including carcinoma, and that you've seen 3 examples. A seminoma, the patient did not know that they had a testicular tumour, and that was a retroperitoneal lymph node picked up on MRI, and a search went for it, and they found it. The second one, the hamartoma, she was rapidly put through the system of lung referral, and was made a rapid diagnosis of a large bronchial hamartoma, but it could have certainly been a carcinoma. And that, again, was our opportunity. So in sports imaging, yeah, okay, you know, we can grade it, we talked about that, you know, what's the prognosis, we can have a guess at that, but really, you know, this is kind of it, right? Look at everything else before answering the clinical question and avoid satisfaction of search, which means that you see an abnormality and then your brain switches off. You go, meniscal tear, oh yeah, okay, fine. Oh, by the way, he's got an osteosarcoma just in the bottom of the fibula that you've missed. So look for other injuries and other pathology other than the area of interest. Because what we want to be is superheroes, you see. And here's Superman using his X-ray vision in a more productive way. Thank you very much.
We've heard a lot about how to image injuries and how to use MRI and ultrasound. And really, I've got quite a simple task, which is just to talk about when to image acute injury. And I'm going to really just stick to these 2 areas. We're going to talk about muscle and bone a little bit. And just to make it absolutely clear, there's no data to tell you when to image any of these injuries. So this is all opinion-based. There's really very little in the literature to help us decide when to image. So the first thing you do, if there's no data in the literature, is you look at the pathobiology. And this is the pathobiology of muscle injury. So the injury occurs at time 0 here. And then this is the healing phase that patients go through. So they get platelet deposition in the first few hours, followed by an inflammatory response leading to proliferation and remodeling. And for those of you who deal with muscle injuries, it's quite interesting to see that actually the healing phase stretches out to about 100 days. So although the player may be back in 17 days, 20 days, 6 weeks, whatever it is, in actual fact, remodeling occurs right out for quite a long time after the injury. And that's sometimes quite useful when you're talking to athletes and they're saying, I'm still feeling symptoms. Well, their body's still healing that injury. So there's still time to go, even after 30 days, 40 days. What are you actually looking at when you're looking at muscle injuries? Well, these are the sort of things that we see. Fibre disruption is obviously the thing that you're really wanting to see, so you're wanting to be able to assess how many fibres have actually been disrupted. Hematoma is very useful in really acting as a sort of contrast agent to show you the amount of fibre disruption that's occurred. And then in later stages, you tend to see inflammatory action, whether the muscle is regenerating or you're forming scar, or whether you're getting denervation change related to the muscle tear. So really, we're just going to look at the early appearances. Ultrasound and MRI are the main 2 modalities that you're going to use. And with ultrasound, what you're really relying on is contrast between the hematoma and muscle. And this tends to be best 48 to 72 hours post-injury. And I'll show you why that is in a second. You can also look for other findings, such as change in fibre orientation or actual fibre disruption. So sometimes people look at the pennation angle, especially in the big muscles like the gastrocnemiae. It's quite useful to look at the pennation angle change, because that will tell you actually the craniocaudal length of the injury. So these are quite hard to come by. This is one from the Commonwealth Games. This was a long jumper who came straight off the pitch with a hamstring tear. This is the biceps femoris. And you can see a 20-minute-old hematoma at ultrasound. And this is the hematoma here, this bright tissue coming around the biceps femoris on the medial side. And you can see it's very similar in echogenicity to the subcutaneous fat. So it's actually very difficult to delineate an acute hernia. This is a slightly older one. This is a 2-hour tear in a footballer. And this is a medial head of gastrocnemius tear. You can see the actual tear is quite small. And the hematoma is a lot larger because it's tracked into this space between the aponeurosis of soleus and gastrocnemius. And so you can see there's a difference between the size of hematoma and the size of the tear. And one of the things that we see is sometimes people grade the hematoma, rather than the actual fibre derangement. So you have to keep your eyes focused on the tear site itself. And you can see the hematoma again at 2 hours is still very hyperechoic on ultrasound. You can see it very nicely on the MR scan. And you can also see that increased pennation angle. So they should come in at a nice shallow angle, the fibres. And at the tear site, you can see the fibres are all bunched up and are coming in at virtually 90 degrees to the aponeurosis. And so that's really the clue that the tear goes from there to there in this patient on ultrasound. This is a tear at about 36 hours, and what you can see now is that hyperechoic echo texture to the hematoma is reducing, and now this is virtually the same as skeletal muscle. So this is the tear just sitting around here, the hematoma, and you can see it's isoechoic to muscle. So what I can tell you is the perfect time to miss a tear or a hematoma with ultrasound, and that's about 36 to 48 hours. And then, as you go past 5 days, what you tend to see is the hematoma liquefies. So you can see here, this is a gastrocnemius hematoma between gastrocnemius and soleus. And you can see that it's beginning to liquefy, and you've got these solid bits of hematoma with liquid around them, delineating them. And that's why we tend to wait till about 10 days in order to perform aspirations of these hematomas, because you're waiting for it to liquefy so it can be easily aspirated. This is just another sign that you'll see on ultrasound. When you see loss of fibre definition is one of the things that you look for. So you can see the fibres very clearly in the longitudinal section, and you can see that you're losing it over this large area of muscle. So this is a contused damaged muscle here. So in summary, you're really looking for contrast between hematoma and muscle, and really it's best to wait till after 48 hours to try and grade these tears with ultrasound if you're going to try and use that. But the majority of sports imagers will use MRI to do the grading at an earlier stage than that. And this problem with ultrasound tends to result in relatively low sensitivity for muscle tears compared to MRI. This is a study from an Italian group that looked at 81 soccer players, and they graded the muscle injuries into minor and major injuries. And you can see that the sensitivity for minor injury is only 3 out of 4, and even for major injury, you're missing approximately 1 in 12 injuries. And there were 10 false negatives for ultrasound in the 81 players. So you can see that ultrasound really isn't going to be a very useful screening tool for muscle injury. MRI you can virtually perform immediately. Looking at bone injury, using the same process to the muscle injury, you're looking for fracture hematoma. That occurs in hours after the injury. Then you get inflammatory reaction and inflammatory exudate around the fracture site. And then you get granulation tissue and callus formation over days after that. The imaging features, the images that you can use are obviously X-ray, CT, and MRI. X-ray and CT are great for displaced fractures, not so good for undisplaced fractures where you tend to use MRI. So this is a bone injury that we saw at the 2012 Olympic Games. And you can see here this patient has a fracture of the posterior rim of the acetabulum. And the thing that I'd like you to note on this is it really doesn't look like the fractures that you see in your clinical practice. This was quite early on, it was only hours old, and there really was no inflammatory reaction around it in the bone, and there wasn't that much in the way of soft tissue reaction. So sometimes if you image them very early, you can run into problems. This is the more traditional feature that we see, where you see a patient with a normal X-ray with a hip injury. Our practice is to use CT, and on the CT scan there was a question whether there was a tiny little fracture here on the CT. We tend to use CT because it's quickly available and shows us the displaced fractures effectively. But actually the patient's fracture was in a completely different place to the nutrient vessel, and he developed sclerosis over the next 10 days as a band going around the femoral neck. In actual fact, we normally use MRI to detect these fractures, which shows us very nicely the fracture lines on the T1 weighted scans and gives us an easy diagnostic challenge. So in summary, imaging of acute injury for muscle, we tend to use MRI. You can use MRI virtually any time after the injury, and we save ultrasound as a second-line investigation for problem-solving and intervention. If you're going to try and look at muscle with ultrasound, you need to wait a little while before you do it. And then for fractures, just be wary of the limited inflammatory response in the first few hours that may reduce your conspicuity at MR, and use CT or MRI, just remembering that MRI is the modality of choice for undisplaced fractures. Thank you.
We use gadolinium-based contrast agents to enhance diagnostic imaging in a conventional MRI and to aim to improve our diagnosis. And in musculoskeletal imaging, its main uses are in intra-articular use, and we typically use Magnavist, and intravenous use, particularly for looking for enhancing synovitis in rheumatological conditions, perhaps in tumour assessment and post-spinal surgery. MR arthrograms, we perform an intra-articular injection either under ultrasound or fluoroscopic guidance, and then we go on to this sort of imaging. It can be used for multiple different joints, particularly in the hip and shoulder. It's thought to improve accuracy for labral tears. It's specifically good at looking at cartilage, particularly cartilage narrowing or full thickness chondral defects. You may be able to see intra-articular bodies, which you may otherwise not see. You can assess the ligamentum teres in the hip. In the shoulder, you may be able to look at glenohumeral ligament injuries or subtle pulley injuries. For the wrist and elbow, it makes it more accurate at looking at ligament tears, which we've already heard about, and also, again, looking at cartilage. And the foot and ankle, it may be particularly useful to look for specific unstable osteochondral injuries. And also, again, looking at cartilage. And there have been reports for looking at synovial thickening, in particular impingement syndromes of the ankle. In post-intravenous contrast, again, looking for synovitis and rheumatological conditions, it can be more sensitive at looking at enhancing synovitis, neuroinflammatory arthritides. In tumour assessment, it's probably not used as much as one would think, and specifically, it's often used to distinguish between solid and cystic components, maybe pre-biopsy, where you want to know where the solid component is to biopsy. Can be used in things like peripheral nerve sheath tumours, where they typically light up like a light bulb, but they're the main indications. It is traditionally used in post-spinal surgery to help perhaps distinguish between a recurrent disc or fibrous tissue. And I'm going to mention degeneric imaging. Although not in routine clinical practice, we give intravenous contrast to look more specifically, exquisitely at the cartilage, which we've heard a lot about, particularly from the hip surgeons yesterday, wanting to know more detail about what's happening with the cartilage. However, since 2014, there's been extensive published literature about the accumulation of gadolinium in brain tissues and increased risk in children and pregnant women. We don't know really what the effects of it are, but we do know it is accumulating in brain tissue and many months after the administration of gadolinium. So this is definitely influencing what we should be doing now. As a consequence of this, the European Medicines Agency in July this year has just suspended the use of linear agents, 4 linear agents, which are shown there. They are more likely to be absorbed by certain tissues, including the skin and the kidneys. So we've moved to only using macrocyclic agents, except for Magnavist, which is a linear agent, which is still allowed to be used for intra-articular injections. And they have recommended that macrocyclic agents only be used at the lowest dose that enhances images sufficiently to make the diagnosis, and only when unenhanced body scans are not suitable. And just this month, on September the 11th, the US Foods and Drugs Agency have actually suggested that there should be warning labels applied to gadolinium. And just having heard Mr. Hassan yesterday talk about the medical legal issues, it does raise the question of whether we should be really obtaining consent for patients before administering gadolinium. So, reflection of our use in practice. I think some of us are going through this at the moment about whether really we should be changing our practice with gadolinium. So, arthrograms. Should we be perhaps adopting the use of saline with proton density imaging versus T1 imaging? 3T imaging versus MRI. We've heard from Jerry and Phil about that. Should we actually be moving towards just 3T imaging? Post-spinal surgery, many units now don't use gadolinium in post-operative spinal cases. They find axial T1s are acceptable, and on the odd occasion, just recalling the patient if there's atypical appearances. Synovitis in inflammatory arthritis assessment, maybe we should just be sticking with ultrasound and using that as our main imaging modality. We've already gone through that MR arthrogram versus 3T imaging. There are many papers on this, and some will say do 3T imaging prior to doing an MRA, and only an MRA if your 3T imaging doesn't provide the information you require. Other side effects to be aware of, we know that it accumulates in other tissues such as the skin and skin plaques, and we know that there is this risk of nephrogenic systemic fibrosis, which is another serious side effect. So just to be aware of that, gadolinium isn't entirely safe. So in summary, when to use gadolinium, we now know that it accumulates in brain tissues. The EMA have suspended the use of linear agents. The FDA are calling for warning labels. So really, we should only be using gadolinium if we really feel it improves our diagnostic performance. MRI arthrograms, we could be perhaps moving to normal saline, or in fact using 3T imaging, as we've already heard. And for synovitis and inflammatory arthritis, maybe ultrasound assessment, tumour assessment only when required, and obviously post-spinal surgery only in atypical appearances. Thank you.
Thank you very much indeed. I'm going to just talk about the sort of general drugs that we use in radiology. I've got a couple of disclosures. Importantly, we're just going to talk about an overview of the potential complications. So we're going to go through a few bits and bobs. Radiation is actually pretty bad in a lot of cases, so we just need to highlight that. Local anaesthetics, steroids, prolotherapy, bit on GAD, although we've just heard a whole load on that, and then drugs in pregnancy and breastfeeding. Firstly, radiation. This is the thing that we all sign the forms for, chest x-ray, this x-ray, that x-ray. But what are we actually doing? Well, these patients are getting a dose of radiation. So let's just deal with the units first of all, something that confuses the hell out of most people. Firstly, absorbed dose. It's measured in grays. If ever you see something in grays, the unit of grays, forget it. It's not very helpful. What we do is we take that unit, then we put a few little fudge factors depending on what tissue it is, how it's absorbed, so on and so forth, and what the energy of those x-rays are, well, not necessarily x-rays, but radiation. They can be particulate radiation, i.e. beta particles, electrons, or they can be, like polonium-210, large heavy nuclei, alpha particles. We put a fudge factor there, and then we call it a dose equivalent, and that is measured in sieverts. So sieverts is the unit that we're all interested in. So what's our background dose? 3 millisieverts per year. That's fine. We've got that in our head now. From 1 to 10 millisieverts, there's really no good evidence as of yet to suggest that it causes any risks. So, hey, we're all in the clear. Not quite. What we need to do is draw that graph backwards and extrapolate, and we can look at some relative risks. So, there was a big paper by Matthews. I'm not going to go through it, but basically what it did was looked at a whole load of pediatric patients who had cancer and who had lots of imaging, so they weren't the kind of best patients, but they found there was a significant increase in the risk of cancer related to the radiation that they received. So what are we actually prescribing when we write these? Well, we're giving them a dose of 2 millisieverts for a head, this is a CT scan, 7 for a chest, abdomen pelvis 10 millisieverts. So we're starting to hoof up the dose here. So whenever we order these investigations, we need to have that in the back of our mind. Do we really need to do it? Local anaesthetics now, very quickly. Always a big question is it going to affect the cartilage? Is the cartilage going to drop off, or are they going to clunk it because we've done something to their heart? So we're left with this bit of dilemma. Lignocaine, okay, but it's really the drugs like bupivacaine that we really need to just highlight. The chondrotoxicity is dose-dependent, time-dependent, and bupivacaine has the porous profile. It's actually a mixture of two drugs. It's actually bupivacaine, but it has this sort of mirror image. So there are two. There's a D form and an L form. And it's the L form that is actually the levobupivacaine, or the chirocaine, is actually much safer from a cardiac point of view. But unfortunately, it's much more chondrotoxic. So bottom line is we're probably going to have to stick with bupivacaine for the moment. Steroids. Steroids are part of a group of immunosuppressive drugs, all sorts of them, cyclosporin, alpha tumor necrosis factor, so on and so forth. What do? They're immunosuppressive and they're anti-inflammatory as well. So we make use of that anti-inflammatory process, but it does have a lot of drug interactions. So here are the drug interactions. I'm going to go through all of them individually now. And there's a prize for whoever remembers them. So you can't remember them all. It's just too much. And are we realistically going to improve the condition of the patient? If we really think we are, then we should be considering the use of steroids on the background of taking a good history, knowing what drugs they're on. Now, steroids do affect things. If the patient's got TB, vaccinations, diabetes, it can send the brittle diabetics, it can really affect the diabetic controls, send the blood sugars up. It can affect the anti-epileptic medication, so check to see patients are on those. And HIV medications, probably the most important thing. HIV meds, there's all sorts of different types of medication, from entry inhibitors all the way through to the protease inhibitors. I'm not going to go into any great detail, but one of the protease inhibitors is called ritonavir. So if anything sticks in your mind, ritonavir is the drug for this morning. And that affects this enzyme in the body, cytochrome P450. What it does, that enzyme is necessary to break down the steroids. So if they're on ritonavir and you give them steroids, basically you're giving them the most enormous hoof of steroids. And what that can do is that then switches off the adrenals via the inhibitory feedback mechanisms. And more importantly, what that does is that keeps a massive dose on board. So you can actually make them Cushingoid and then give them acute adrenal failure. So basically you can kill them. Steroids and skin changes, well, there are problems. You can get fat necrosis here. You can get skin colour changes, and you can get quite marked depigmentation as well. So all these patients should be consented for this kind of problem, because it may well come back and haunt us. Other problems are acute reactions such as Stevens-Johnson syndrome. Thank goodness, extremely rare, but you can see how horrible and how nasty that is. Steroids and pregnancy, there's tons and tons of stuff written about it, and you always get really very paranoid about it. So I went to, when I was at Chelsea Westminster Hospital, went to the pharmacy and said, look, I need something just so I can actually explain to these patients. And I keep this little printed thing on my phone and I read it out to patients as well. But the bottom line is that we shouldn't really be giving steroids to patients who are pregnant, but if we have to give them to pregnancy, try and make sure it's in the later trimesters. We can give it in the early trimester, and a single one-off dose of prednisolone is probably, methylprednisolone, depomedrone, is likely to be fine, 40 milligrams. Steroids and breastfeeding, one-off dose, 40 milligrams, depomedrone, absolutely fine as well. Prolotherapy, I trawled through all the literature for prolotherapy, couldn't find any adverse effects for that. Gadolinium, we've just heard all about gadolinium. Bottom line is, just to reiterate it, that gadolinium itself, on its own, is really, really toxic. So we have to use it as a chelate, combine it with other chemicals to make it less toxic. And what I did was I did a little bit of playing around with maths on the back of a fag packet. And what that actually says, for every 10 requests of gadolinium per day over 200 weeks, we'll probably have one fatal reaction, on the assumption that fatal reaction occurs in 1 in 100,000. So that's quite a lot. We've got to be very careful. We've heard about nephrogenic sclerosing fibrosis, but really nasty problem, causes these horrible problems in the hands and contractures. So drugs. Just be careful. Many thanks.
I was given this title and tried to make something of it. And so I'm going to turn to the meniscus and also talk a little bit about cartilage. What I thought I'd do in the brief time we have is think about what we're actually looking for, think about where we're going to look for it, know where to look for it within the joint, and also watching out for one or two pitfalls, some of which we've already heard a little bit about already. So what are we looking for? Let's think about osteochondral injury to start with. In the acute situation, such as you see in the ankle on the top image there, we're looking for something that's going to correspond very much to the defect that we're seeing. So you see a nice inverted talar dome osteochondral fragment there. In the chronic situation, though, things change. And the easy way to remember this is that anything can happen, really. You can get proliferation of new layers of cartilage. The fragment may completely disappear. It may be resorbed. Or you can get degenerative calcification within a fragment that initially perhaps wasn't calcified. The other thing that's going to affect what we're looking for in terms of osteochondral injury is the age of the patient. We learnt in our histology lectures many years ago, in my case, about the tide mark, the calcified layer of cartilage that forms between the trabecular bone and the cartilage. And that develops during life. So by the time we're adults, we have a fairly thick tide mark, and that represents a weak point between the collagen fibers of the cartilage and the underlying bone. And so we'll tend to be looking in the acute situation for a cartilage fragment without any calcification in the adult situation. In children, that tide mark hasn't really developed yet. The calcified layer hasn't properly formed. And so you don't have that protective layer over the bone. So it's much more likely you're going to have an ossified fragment associated with the cartilage. Know what you're looking for in terms of whether you've got bone present. You're going to look for fat signal within the bone, and that's obviously going to be dark on fat-suppressed sequences. The trouble comes really when you haven't got bone associated with it, and we've seen a couple of really nice examples already today, but non-calcified cartilage, depending on the sequence, can look very, very close to fluid signal. So in the upper set of images there, highlighted with the blue and yellow images, arrows, you can see the osteochondral fragment very nicely. There's a bit of bone associated with that. If we turn to this lower image, we can see the osteochondral, or the chondral, I should say, defect nicely in the knee. But the chondral fragment is much harder to see. I liked Adam's description of the railroad sign. I thought that was very good. Except I keep thinking about spondyloarthritis every time I hear about it, but there you go. When you're looking for fragments, technique helps. We've heard a little bit about MR arthrography. I think in the acute situation, one of the things we forget is that, particularly with professional and elite athletes, we're usually imaging in a very, very acute situation after an injury has occurred to the joint. And these patients will almost always have a joint effusion. And so before jumping in and doing an MR arthrogram, have a little think about whether actually we're going to need arthrographic contrast in there. Anyway, you've got fluid in the joint. You may get away without it, even where the evidence would suggest that MR arthrography is important, which is why I do a lot of my MR arthrography under ultrasound guidance, because I can actually have a look before I put any contrast in and see if there's a joint effusion there. And if there is a joint effusion, I might elect not to give the gadolinium. But there's no doubt about it, fluid, be it effusion or be it arthrographic contrast, helps you identify the fragment. We see an osteochondral or a chondral lesion there with the yellow arrow, and the body nicely shown in the posterior aspects of the shoulder joint with the blue arrow. We can see also in a knee here a large osteochondral defect in the medial femoral condyle, and it's very easy to identify the body shown with the blue arrow there. But what's much harder to see in the same patient is there's a second body situated behind the posterior cruciate ligament there with the yellow arrowhead, which isn't surrounded by fluid and is much harder to see.
It's also very useful when you've got fluid in to spot the unstable fragment before it's actually detached. It's a very nice image here of a delaminating aspect, a piece of cartilage which is about to be shed off the the distal femur. You can see the gap with the fluid associated with it. So this is a barely attached fragment. Much, much easier to see if you've got some fluid in the joint. Knowing where to look is the other thing to think about. When you've got large bodies in a joint such as this, it's really not a problem to identify them. You've got to know about recesses in the joints. Here's a good example. Here we have a popliteal cyst with a body sitting in the Baker's cyst or popliteal cyst, which we know communicates with the joint. Have a closer look at this image. We can identify another body as well, and that's sitting in the popliteus tendon sheath here. So knowing where these recesses exist is important. The biceps tendon sheath in the shoulder is a good example. Here's another popliteus, sorry, I've forgotten to put this one in actually, but this is another example of a popliteus tendon sheath meniscal fragment here, shown with the yellow arrow. The blue arrow is on the popliteus tendon. Another area is the ankle. The flexor hallucis longus tendon sheath communicates with the ankle joint in the majority of patients. You can see with the yellow arrows here the osteochondral lesion in the anterior tibial plafond. And when we look down into the sole of the foot, just distal to the sustentaculum tali, you can actually see the fragments from that sitting in the flexor hallucis tendon sheath. So it's worth knowing about these recesses. Finally, I'm not going to say much about the fat pitfall because Adam's already highlighted that, but there's no doubt about it, T1 imaging is really useful. The yellow arrow points to a possible osteochondral body, a possible meniscal body here. The T1 imaging, bottom right, shows this is actually fat. What we also highlight in this study is another pitfall shown with the blue arrow here, which might easily be interpreted as a meniscal body, but in fact represents the intermeniscal transverse ligament. And that's my final pitfall, these transverse ligaments, the meniscofemoral ligaments, which can look very much like detached fragments from the meniscus, so we need to be very aware of that. Perhaps the biggest catch is this oblique intermeniscal ligament, highlighted with the yellow arrow there, running diagonally across the knee joint, which can look very much like a bucket-handled fragment if you're not aware of that pitfall. The horizontal flaps, similarly, when they flip outside the joint line, are very difficult sometimes to see. So knowing that they're there, or knowing they may be there in the first instance, is the key thing. So my take-home points: recognise osteochondral bodies can grow, keep looking for more, look for, if you've got joint fluid, it really helps, really understand the joint anatomy, and think about those meniscal ligaments and the horizontal flap tear. Thanks very much.
Interestingly, the oblique intermeniscal ligament, we see it really nicely on MRI, and the surgeons often don't see it, and I think it's because it's covered in the ACL synovial sleeve. So often when I talk about that, the surgeons don't really know what I'm talking about because they don't actually see it like we do.
Thank you very much, Jerry, for the invitation. Jay, sorry. So no disclosures. So we know already, I mean, the whole theme of this conference is sports injuries. They're most commonly knee and ankle, probably, and they'll be assessed with a combination of history, examination, and various imaging techniques, maybe radiographs, ultrasound, and MRI. And I think that the imaging findings can be categorized into a variety of scenarios. So the imaging may be completely normal. The imaging may show only an abnormality related purely to the trauma, such as a soft tissue injury or a bone bruise. The imaging may also then show an incidental non-neoplastic lesion, which is of no clinical relevance. The imaging may show an incidental neoplastic lesion, which is of no clinical relevance. Or the imaging may also show an incidental neoplastic lesion, which is of clinical relevance. Now, clearly, from our point of view at Stanmore, the only cases we would like to have sent to us would be those in number 5, but that's by far the least common scenario. What we see most commonly are those in cases 3 and 4. And what this probably suggests to us, or to me, is that there is a lack of confidence from the reporting radiologists as to what they're looking at, which is fair enough because tumours are very rare. There may be a lack of confidence in the report from the treating clinician, which again is fair enough. Or there may be a lack of clear knowledge as to how a lesion should be treated if the diagnosis is clear. So as far as I'm concerned, it's quite acceptable that these patients should be referred to the tumour service for what would hopefully be a more definitive opinion. Now, if we just look at some examples of the sort of things we see, this is a classical stress fracture seen with sort of chronic injuries, trauma. Hopefully that shouldn't be a difficult diagnosis to make. The T1 weighted image on the right shows that there's no underlying marrow abnormality, but stress fractures can be associated with underlying tumours. If we look at this case now, this is a young lad, I think he was about 11 years old, the son of a professional rugby player, presented with shin pain, and an MR appearance which was thought to be a tumour, referred as a Ewing sarcoma, although the appearances are certainly not classical, so referred to us for a CT-guided GA needle biopsy. Now the CT, just prior to biopsy, shows the stress fracture and the multi-laminated periosteal response. We did not proceed then onto a biopsy, and clinically and radiologically that went on to heal after a few weeks. So the appearances can be unusual. One of the commonest non-neoplastic lesions we see in the immature skeleton is probably the cortical desmoid, seen both on plain radiographs and also here on the CT image in the posterior aspect of the knee, related to the medial head of gastrocnemius origin, and it's thought possibly to be a chronic traction injury at that site. So that's a fairly common thing that we do identify. Probably the commonest neoplastic lesion, which is of no clinical relevance that we identify, is the non-ossifying fibroma, typically in the distal femoral metaphysis, or more commonly the distal tibial metaphysis, and that's a fairly straightforward radiological diagnosis. These can be associated with stress fractures and therefore could be symptomatic, and they're well shown on MRI. Enchondroma is probably the commonest lesion, incidental lesion we will see on MR studies, and it's shown to be present in about 3% of knee MRs and 2% of shoulder MRs as an incidental finding. And it's not uncommon to, when you look at the report from the referring clinician, to state that it's an enchondroma, but then the rider is there that a low-grade chondrosarcoma cannot be excluded. Again, fair enough. That's why they're sent to us for a further opinion. Now, what about incidental lesions which are of relevance? Now, this is a young guy who avulsed the tibial attachment of his ACL. He's got a big joint effusion, but it was identified on the MR that he's got gross hypointense thickening of the posterior femoral cortex, and this in fact turned out to be a parosteal osteosarcoma, a low-grade parosteal, incidental finding clearly of relevance, and he went on to have a distal femoral replacement. Now, there's really not much in the literature about tumours presenting with sports injuries, but this is one paper I found. And it's interesting that even though, of course, osteosarcoma and Ewing sarcoma are very rare, there's a history of trauma in almost half the cases of patients presenting with osteosarcoma and a quarter of patients presenting with Ewing sarcoma. And they found that night pain, which is a red flag sign that we always tell people to think about, was a very uncommon finding. So it is a problem clinically. You've got a history of trauma, no night pain. You cannot exclude the possibility of a significant underlying lesion. What are the consequences then of a wrong diagnosis? This is a CT scanogram, couldn't find the plain film, which is maybe part of the problem here. The CT scanogram done at the time of biopsy, 40-year-old male with thigh pain. The external radiological diagnosis was fibrous dysplasia, and therefore nothing was done. The actual radiological diagnosis is grade 2 chondrosarcoma, so this patient had really 7 months of unnecessary pain before he was referred to us and had a biopsy proving the diagnosis and went on to a proximal femoral replacement. What then are the consequences of a delayed diagnosis potentially? So this is a 17-year-old presenting with knee pain in October 2008. The X-ray is reported as normal. I think, again, not unreasonably. Treated with physiotherapy, returned approximately 10 months later with a high-grade central osteosarcoma into the joint with lymph node metastases. So the possibility of missing something major with a normal-looking X-ray is a big issue. You need to go on to thinking about MR when the symptoms are significant and the X-ray is normal. So in conclusion, when should I refer to a tumour centre? Well, I would suggest to you always. Thank you very much.